Thank you, Tony. In the spirit of this meeting, it's my thought that all of you see patients with liver disease and that there are really not enough gastroenterologists or hepatologists in the world to really manage all the patients with liver disease. And so the concept of a partnership in management is really important, and that's why I'm particularly glad to have you here today. I'm going to be talking really not so much about every aspect of portal hypertension, but mainly about variceal hemorrhage. I'd just like to remind you, and this slide does remind you, that cirrhosis has many manifestations, some of which relate to hepatic insufficiency, not enough liver cells there to get the job done, and other consequences that come not so much from liver insufficiency, but from the presence of portal hypertension. And the manifestations of portal hypertension in general are variceal hemorrhage, ascites, and encephalopathy, which may also be in part related to liver insufficiency. These are all kind of interrelated things. My presentation this morning is going to focus on some of the newer aspects of management of variceal hemorrhage, and I'll speak a little bit about an important presentation at the AASLD that relates to ascites as it relates to the management of portal hypertension and bleeding varices. So for those of you who need a reminder, people who have cirrhosis can develop esophageal varices. The studies that document the actual rate of development, I think, are a little on the weak side, but it's generally accepted that somewhere around 8% of individuals with cirrhosis per year will develop esophageal varices, that they don't generally develop when the portal pressure is elevated above normal, but not elevated above 10 millimeters of mercury. So a wedged hepatic venous pressure gradient of more than 10 millimeters of mercury is generally required before esophageal varices will form, and that small varices may remain small, but they may also grow, and that bleeding, the risk of bleeding, is related not only to the size of the varices, with large varices being more likely to bleed than small, but also importantly related to the degree of hepatic insufficiency. So those who have advanced liver disease as measured by a child's Pew score of B or C, or those who have endoscopic signs of red whale markings, these are the ones that are at risk for bleeding from esophageal varices. And then the final general point is a person who has Child's A, very well compensated cirrhosis, and who bleeds, tends to tolerate it very well. It's those who have more advanced liver disease that are less tolerant of the effects of esophageal variceal hemorrhage. So on your left is a endoscopic photograph of a esophagus that has large tortuous esophageal varices, and on the right is actually a gastric varix, which you can see is spurting, and obviously this is the sort of thing we want to avoid wherever possible. I'm going to remind you that there are several practice guidelines out there. One was published in 2007 and has been endorsed by both the AASLD and the American College of Gastroenterology. I was on the writing panel for that. It was published in 2007, which means all the data in that guideline is from 2006 or before, so it's a little dated at this point and probably in need of an upgrade. Now, because of time, I'm not going to read through all of this slide. This is one that I would like you to go to the website, download it, and get a general sense as to where the guidelines are going. Divided into three sections. One, which is represented on this slide, what do we do about patients who have never bled from esophageal varices? And the highlights here is we want to screen, and if they're anything but small, we want to manage them either with beta blockers or with band ligation, and it's non-cardioselective beta blockers that we use rather than the cardioselective beta blockers. And the other thing on the last bullet on the right-hand side is if you use beta blockers, they must be titrated. You can't just start someone on a dose of beta blockers and say, that's good enough. And when we look at compliance with practice guidelines, this is an area where many practitioners fall short. So beta blockers are good, and we'll talk more about that later, but they need to be adjusted to the maximum tolerated dose. This slide represents management strategies for the patient who is actively bleeding from esophageal varices, and the bolded portions of the bullet points are all I'll pay attention to here. But again, I would ask you to go to the website, download this slide, and get the nuances that are here. We don't want to over-transfuse patients who are bleeding. The second bullet indicates that we want to use antibiotics. This is not intuitive, but it is true and evidence-based. We want to use vasoactive therapy, and one of the abstracts I'll be highlighting has to do with the selection of vasoactive therapy, and the rest we won't highlight today. Once a patient has been successfully resuscitated and they're no longer bleeding, we need strategies to reduce the likelihood that they'll have a second variceal hemorrhage, and these are the guideline recommendations about preventing rebleeding. And again, highlighted here is information about beta blockade, again, needing to adjust it as an adjunct to band ligation. So the other background information you all need to know is we'll be talking about Child-Pugh score, MELD score. These are basically two different ways of assessing the severity of the underlying liver disease. As you know, there's an awful lot of people walking around who have cirrhosis and don't even know it. Their numbers are perfect. They just happen to have cirrhosis. And so given cirrhosis, how do we assess whether or not this is bland and not likely to do a person in, or whether it's more severe? And the historical way we've done it since the 1950s is a Child-Pugh score. In the last decade or so, the MELD score has also become useful, but they both have their uses, and the literature and scientific studies depend on both of these things. For those of you who can't calculate a Child-Pugh score on your own, there's a calculator for that, and none of us can calculate a MELD score on our own, so there's a calculator for that. And the website is here, and again, when you download these slides, you can get that web address. So acute variceal hemorrhage, we're going to focus on that for a minute. It's not at all curious that we should resuscitate, and that means give them IV fluids and use vasoactive therapy. Again, antibiotics, this is a thing I really want to hit on because many of you are not using antibiotics. We've done our own survey nationally. We've done a survey in Northern Ohio, and compliance with the use of antibiotics is really extremely low, and so we need to do something about that. All the other things here are more or less self-evident, and what you do in almost anybody with bleeding. This actually is an abstract that was presented at Digestive Disease Week in 2011, showing you in the darker color that antibiotics were used in only about 20% of individuals with variceal hemorrhage. The abstract was really about the use of order sets to make it kind of an automatic, what do you do when you have someone bleeding? Get up the order set and follow all the instructions, and this shows that you can markedly increase compliance with everything, but the only thing that was statistically in need of improvement was the use of antibiotics in the setting of acute variceal hemorrhage. So don't forget to use antibiotics, whether or not you use an order set. Does it matter how you give the antibiotics, PO, IVs? Doesn't seem to matter. There are randomized controlled trials with multiple different antibiotics, all of which show a benefit compared to placebo, and most of these benefits are not only in terms of reduced incidence of rebleeding, but an increased survival rate as well. How long do you give them? Well, the range of the randomized studies are listed here for about a week or so, and again, you have your choice of many different antibiotic regimens. What I'd like to focus on for a minute then is, does it matter which vasoactive drug you use? There's a lot of them out there, and does it matter? And so the ones that are most written about and most studied are terlipressin, not available in the United States, but available in many parts of the world. Somatostatin, not available in the United States, but available in many parts of the world. And octreotide, which is available everywhere, and it's pretty darned easy to use. So does it matter which one you use? There are some studies which suggest that actually a survival advantage accrues to those who get terlipressin. And so it's important for us to know in updated studies whether or not this really holds up or not. Does it matter? Here is a study presented at EASL, not at this AASLD meeting, but at EASL in 2011 from Korea, a randomized controlled trial which compared these three agents, and as it turns out, it didn't matter at all. Hemostasis was achieved in 88%, rebleeding within 5 days at 4.2%, and adverse events not different at all. So from this randomized controlled trial, which is actually pretty big, 780 patients, it doesn't seem to matter very much. Here is another somewhat smaller study, this time from India. This was an abstract 199 at this year's AASLD meeting. This is a comparison of terlipressin, somatostatin, and octreotide in acute variceal hemorrhage, a prospective randomized trial of 210 patients who were selected from 268 who were considered for inclusion, and you can see the details of who was randomized to what and what the regimen was for each of these programs, and those are fairly typical dosages to use. Inclusion criteria, exclusion criteria, no particular surprises here or red flags in terms of criticizing the study. I think these are fairly standard for studies of this type. And if we look at the comparability of the patients who were randomized to the three treatment arms, not much difference at all between the baseline characteristics. And basically what the investigators found is that it didn't matter which drug was given. In terms of active bleeding at the time of intervention, the rate was about the same in the three groups. And if you look at failure to control bleeding, death at 6 weeks, or rebleeding within 6 weeks, not much difference at all. I would draw your attention to the right-hand panel, the octreotide group. Although it wasn't statistically significantly different, there were more failures to control and adverse events in the octreotide group, so we may need to pay a little bit of attention to that. What they found, though, that in terms of multivariate analysis, failure to control bleed, the creatinine was important, the number of units of blood transfused was important, and the presence of portal hypertensive gastropathy was actually associated with an improved likelihood of controlling acute variceal hemorrhage. Child's Pew score and a low sodium were associated with rebleeding within 6 weeks, but nothing else was, including which vasoactive drug they got. In terms of predictors of death within 6 weeks, again, the treatment rendered didn't make any difference, but active bleeding at the time of endoscopy or alcohol as an etiology was important. And so the authors conclude somatostatin, terlipressin, octreotide are equally effective in controlling acute variceal hemorrhage, and no particular differences with respect to rebleeding, death at 6 weeks, duration of hospital stay, etc. Well, it wasn't placebo-controlled. It does confirm the Korea study that I cited earlier and other studies which suggest these are virtually equivalent compounds. Differences in drugs, if they really exist, are likely to be small, but again, the octreotide group didn't do quite as well numerically, and I do wonder whether a type 2 error is possible. That is, they may be a real difference, but the sample size was too small to really uncover it. So I guess my conclusion to this point, does it matter which vasoactive drug is used? You know, probably not, and since we only have octreotide in this country anyway, that's a good thing for us. So what about acid suppression? If I could have a show of hands, those of you who treat esophageal varices with a band ligation, do you use acid suppression? A show of hands for those who do use acid suppression. Those of you who don't use acid suppression, could I have a show of hands? All right, so we have a couple of people in the audience who are actually complying with a guideline, and the rest of you, riffraff, are not. So let's look at the data. Actually, the guidelines are kind of mute with respect to acid suppression, but maybe we should consider it. And so here is a picture on your right of a black band at the base of an esophageal varix. And here you see an endoscopic picture taken a week or 10 days later showing the band is still there and there's a big ulcer. These are different patients, of course, but there's two ulcers in this case, and it's very well known that ulcers in the esophagus do appear as a consequence of band ligation. So here is a study from Taiwan, abstract number 200, a controlled trial asking the question, you know, maybe we don't even need to use a vasoconstrictor. Maybe a PPI, a proton pump inhibitor, would do just fine. And so they did a randomized controlled trial of either a vasoactive therapy or a PPI. There was no arm that used both therapies. And again, you have the inclusion and inclusion criteria, which again looked to me to be fairly straightforward. They were randomized to get vasoconstrictor and the vasoconstrictor group got either somatostatin or terlipressin, and the other group got a proton pump inhibitor, and they used the standard therapy for control of variceal hemorrhage, which seemed to be pretty good. And what they found is that they used primary endpoints as listed here, and I'm going to skip to the results. So they got 118 patients randomized into the study, and you can see how they broke out. And again, baseline characteristics pretty similar. They didn't find any difference. They didn't find any difference between treatment failure, failure to control acute bleed, very early variceal hemorrhage, by which they meant within 5 days, rebleeding between 6 and 42 days, number of units, hospital stay, 42-day mortality, no differences at all. So this is kind of an interesting study. They did show that those who were assigned to the vasoconstrictor group and no PPI had not statistically significant but numerically more likelihood of esophageal ulcers and a statistically increased likelihood of large esophageal ulcers and adverse events. So they conclude that after cessation of bleeding by variceal ligation, PPI and vasoactive therapy are really equivalent in terms of initial hemostasis and very early rebleeding, that is, bleeding within 5 days. And PPIs tended to heal, speed the healing of variceal band-induced ulcers with fewer adverse events. And so again, I would reiterate that the practice guideline really doesn't mention PPIs. Most of you in the audience are already using PPIs in this context, so maybe it's just really reaffirming what we already do. It seems to me what we need is a study to show, do PPIs add anything to the simultaneous use of vasoconstrictors and PPIs? But this would take a very large study. So my conclusion is there a role? Maybe, and again, most of you are using them already. My final presentation, abstract discussion, surrounds the notion that beta blockers are something that hepatologists love to use. We use them all the time. We use non-cardioselective beta blockers, and it's useful in primary prophylaxis, secondary prophylaxis, and it's a generally good thing to do, but there's some limitations. So the more advanced the cirrhosis, the less likely it is that a patient's really going to tolerate the added fatigue that comes with beta blocker therapy. They just don't tolerate them very well. The other thing that I've already highlighted is we need to titrate, and most of us are frankly too busy to do this on a regular basis, but it really needs to be done. We've mentioned the side effects. Long-term hemodynamic effects of beta blockers may be lost. And then the thing that has kind of come up recently is a potential for increased mortality in those who get beta blockers and who have refractory ascites. And here is the reference that suggests that, published in a pretty good journal in hepatology in 2010. This was an observational case study of 151 patients, those who got beta blockers and those who didn't. And what you can see is in the setting of refractory ascites that the odds ratio, the hazard ratio of death in the group who got beta blockers was 2.6, statistically significant, raising a caution flag about the use of beta blockers in this category of patient. So this is a cautionary thing we need to pay attention to, and so here is a new study, abstract number 203, largely from Yale, showing that, looking at the problem a little different way, and we'll go through this. The hypothesis of the study that Surstay in the hepatology study kind of got it wrong, because everybody on beta blockers had esophageal varices, but only 4% of people who didn't get beta blockers had esophageal varices. So therefore, maybe the people who got beta blockers were sicker to begin with, and that's why they were likely to die. So the aim of this study was to look at those patients who had cirrhosis and ascites and to determine the prognostic significance of varices and the use or non-use of selective beta blocker therapy. And so here again, your inclusion criteria. One of the advantages of this study is that in New Haven, virtually everybody gets portal pressure measurement. Wedged hepatic venous pressure gradient is determined in virtually everybody there. My own belief is it probably ought to be done much more widely than it is, but okay. So anyhow, here's a study that looks at the issue slightly differently. Pretty big study, 194 patients included, and here are the baseline characteristics of those who had no varices, small varices, large varices. They didn't report any p-values here, and it does look to me like there are some differences in these groups, but that shouldn't be very surprising. They showed actuarial survival curves, and it's a little hard to read and interpret the actuarial survival curves, so I've approximated what I read on these curves. The survival rate in those who had no varices was significantly higher, 78% at 12 months versus 45% if you had large esophageal varices, and the 25-month survival again favored those who had no varices. So actuarial survival was the same whether or not the patients were on beta blocker therapy. The things that did correlate with survival was Child's Pew score and the presence of large esophageal varices. So the authors conclude that varices are associated with shorter survival, that it's an independent predictor of death, and that therapy with beta blockers in the presence of ascites is not associated with a poorer survival. And I guess you can read the others yourself. I think that I largely agree with these conclusions, but again, I would point out that at least in my practice, beta blockers are often not very well tolerated. So my summation is that risk management of patients with cirrhotics with ascites is important. Screen and treat. Be aware of the practice guidelines and be aware that they're a little out of date now. Management of acute variceal hemorrhage requires antibiotics in addition to all the other things that we've talked about. Acid suppression, in my mind, requires an additional look before we can make firm conclusions about it. Beta blockers continue to be useful even in those who have significant ascites. Thank you very much.
Thank you, Tony, for moderating this session. It's good to see you again. I want to thank Pierre and Bill for inviting me to speak on this rather unusual subject of encephalopathy, which only madmen specialize in. One of the interesting things about the hepatic encephalopathy sessions is that unfortunately, when we're on the West Coast, we're always the last abstract session of the entire meeting. So everyone has their plane tickets in their hands ready to run out the door. So it's very hard to talk to the people in front of their posters, but I managed to do it in some cases, and in some I contacted them. The first abstract I'm going to talk about, I have to confess a conflict of interest. This is someone who works with me. In fact, this is a Cleveland Clinic Metro collaboration, and Dr. Perry Algar is the main mover on this. This is sarcopenia cirrhosis, results in more severe and frequent episodes of hepatic encephalopathy. Sarcopenia is just a fancy word for saying reduction in lean body mass or muscle mass. Because of liver disease, the ability loses its ability to make urea, and there's considerable shunting around the liver because of the scarring, so you end up with a lot of ammonia not being disposed of in the fashion that it normally is, and as a result, hyperammonemia occurs. And in that situation, muscle becomes an extremely important ammonia uptake organ to limit the toxicity of ammonia. So the hypothesis or the suggestion of the study was that loss of skeletal muscle mass would lead to an increase in the frequency and severity of HE. And eventually, and this is at the time of submission, we had 101 cirrhotics, 46 non-cirrhotic liver controls, and 32 controlled patients. And in all of these patients, we prospectively measured muscle mass, grip strength, bioelectrical impedance, which is a method for measuring body composition. We had a global assessment scale of their capacity to do work. And then basically using a cutoff of 20 percentile on their lean body mass, we had a look at the relationship of these people who had sarcopenia to those who hadn't in relation to the severity of hepatic encephalopathy. The hepatic encephalopathy was assessed by the New Haven scale, which you all know about, and there's a psychometric scale now for covert HE, which is actually a new term for minimal HE. The results in this study showed we had 55 patients with no HE, but cirrhosis, 30 with covert HE, and 16 with overt HE. The cirrhotics who had sarcopenia had the following: more severe bouts of HE, so more of them got to grade 4, increased prevalence of HE, increased hospitalizations, and much greater functional impairment. These are all very significant statistically. What we've shown in this first study, in a prospective study, shown a relationship between lean body mass and the tendency to get bouts of encephalopathy and the tendency to get severe bouts of encephalopathy. There were a number of studies on LOLA. Those of you who don't know what LOLA is, that's a compound called L-ornithine L-aspartate. It's been used primarily in Europe, and we periodically get abstracts in the ASLD meetings which discuss its efficacy in the treatment of encephalopathy. This particular study is a study on the effect of LOLA, actually an infusion of a LOLA compared to, interestingly enough, rectal enemas with lactose. And this is the reporting of the results of a randomized, double-blind, double-dummy, non-inferiority clinical trial. Now, you remember, because this was rectal steroid or rectal lactose administration, this required quite a lot of maneuvering to convince the people that they were not on lactose. I think I would have liked to hear the discussions about this. But the patients, anyway, all got enemas, whether they were so they got both enemas and oral, IV infusions of LOLA. And in fact, what ended up happening is that there was no difference between the two groups in terms of improvement, but there was very significant improvement in every measure of encephalopathy they could find in this study. So you can say that LOLA IV infusions are similar in efficacy to lactose enemas in improving hepatic encephalopathy in people with overt or more severe forms of hepatic encephalopathy. As I said, the logistics of this study are quite considerable, but I do tend to believe the data. The problem is, of course, there's no placebo here. Lactose itself is a very effective agent, and really what we're saying is probably one effective agent is equivalent to another effective agent, potentially effective agent in the management of encephalopathy. Most of these patients were between grade 3 and 4 and did improve to grade 1. So I do think that there was a significant improvement in both arms of this study. Therefore, infusions, that's IV infusions of LOLA, may well be an effective therapy that we'll be seeing in the future. There was another study which was an oral LOLA intake study in patients with much milder encephalopathy. These are patients who had minimal or covert encephalopathy, and this was the final results of what's called the Porto Alegre study. And basically what they did was a 60-day course of oral LOLA, 5 milligrams TID, or placebo for patients with covert or minimal HE. And there were 64 patients randomized to each 32 in each arm approximately. And again, multiple techniques were used to measure HE, and nothing happened. Very disappointing. This study, again, represents a study that's out of the Cleveland Clinic, is a very interesting study on the spontaneous splenorenal shunt in patients with portal vein thrombosis. And I'm going to show you some data that came from this study. It has been suggested, and I certainly would concur with this, that you see a lot of spontaneous splenorenal shunts in patients with cirrhosis and portal hypertension. And some are seen along with portal vein thrombosis, and some are without. So the idea of this study was to find out whether splenorenal shunts were more likely to be seen in people with portal vein thrombosis or not. The question is whether portal vein thrombosis can lead us to opening up of splenovenous collaterals or not. And what happened in the study was, it's a very large study of 240 patients who were eligible for this, and they followed them up every 6 months with Doppler studies and other imaging studies to show their vascular anatomy in the abdomen. And there didn't show any difference in the patients. There wasn't a tendency, shall I say, for people to get splenorenal collateral formation in patients with portal vein thrombosis, or people who had splenorenal collateral veins were not more likely to have portal vein thrombosis in follow-up. But what was interesting to me as an encephalopathy guy was that the incidence of encephalopathy was far higher if you had both portal vein thrombosis and distal splenorenal shunts. in the same light, and I picked this not because it hasn't been known about, but because this is probably one of the bigger reports on this for a while, that if you have large spontaneous portosystemic shunts in cirrhotic patients with refractory hepatic encephalopathy, and this study, these are patients who didn't respond to therapy, whether lactulose or other therapy for their encephalopathy, and were in encephalopathy for weeks to months. A single center published a paper on their experience with closing these shunts, or looking for and closing shunts in people with intractable encephalopathy. So it's only 10 patients, but most of the studies, just about everything that's been published up to now has been one patient in the radiology literature about once a year. So this is, believe it or not, one of the bigger series in 10 patients from Louvain in Belgium. And they mostly attacked paraumbilical vein shunts that were associated with very severe intractable encephalopathy, and they embolized these and a number of spontaneous splenorenal shunts and one ovarian vein. And what I like to see after this, there was almost instantaneous reversal of their hepatic encephalopathy. These are very unusual patients because they have hepatic encephalopathy despite having good liver function. In fact, they may be even Child's A patients. And so their encephalopathy was cured. And remember, they can't really be transplanted in this circumstance because they don't qualify, at least by the MEL score. And the other thing that was interesting and has been a concern always when you try to embolize these shunts was there were no variceal bleeds or no worsening of ascites. So it seems to be a pretty safe way to manage intractable HE. Another issue came up in Sugimoto's study, which was entitled Regional Reductions in Grey and White Matter Volume in Brains of Cirrhotic Patients Without Overt Hepatic Encephalopathy. This was basically a very sophisticated voxel analysis of MRIs from the Japanese. And what they found, and it's something that has been worrying us a lot, that people who have overt HE, there's some suggestion that you've already lost part of your brain parenchyma. You've lost part of your brain as a result of having multiple bouts of overt HE. But this study is even more disturbing. They did MRI and voxel-based brain morphometry, which can be used to look at brain atrophy, found multiple areas of brain atrophy in people before overt HE had occurred. And there wasn't much difference between minimal and people without minimal HE. So this raises, again, this concern that this brain atrophy or microcavitation or whatever you want to call it is actually occurring fairly early in cirrhosis, and we're not sure what this impact will have in the long run when we time our liver transplants. The trouble about this study is it's hard to believe that there isn't a difference between covert and patients without covert HE. This last study I'm going to talk about is by Chris Record et al. I'm particularly interested in this study because I actually reviewed the grant proposal 8 years ago that was written in England and submitted in England, and I was a reviewer on this. It was actually approved, and then we're beginning to see some of the results of these studies. So it's entitled Induction of Hyperammonemia for Small and Large Intestine in Patients with Cirrhosis with Magnetic Resonance Quantification of Brain Water and Metabolites, one of the longer titles in the meeting. You may not know this, but there's been a big emphasis recently on small bowel ammonia production rates, mainly from the glutaminase enzyme, and people have tended to say that perhaps the colon isn't as important. In this particular study, the authors actually have colonic or delivery devices and enteric-coated devices actually to deliver amino acids and other compounds to the colon, and they showed by giving these compounds that they, without sort of bypassing the small intestine, they could cause the biochemical abnormalities associated with encephalopathy in patients by giving these colonic delivery amino acids in particular. And the markers now for encephalopathy we look at on NMR spectroscopy are decreased myoinositol and increased glutamine, and there's evidence of brain edema occurring. So they gave the patients oral amino acids with enteric coating to get it to the colon, and as a result of that, they saw not only these biochemical changes, but also evidence for cerebral edema in regions of the brain after this colonic delivery. So don't forget that the colon is an important part of the hepatic encephalopathy syndrome, and ammonia from there is just as important perhaps as the small intestine. And I'll just leave it at that. Thank you.